All right, we're live. Everybody, this is Dr. Michael Kaye from the Center for Functional Health, and I'm honored to have with me Jesse Kunwar. She is a nationally board certified counselor and a licensed professional counselor. She is the co-founder of Hope Stream Counseling. Jesse, thank you so much for taking time out of your busy day and speak to us for a while. It's a pleasure having you.
Thank you so much for having me. I'm excited to be here.
Very cool. So I like to share with everybody, how did you get here? So let's first talk about what is a nationally board certified counselor and what is a licensed professional counselor and what the difference is.
The main difference is that the national board is through the NBCC, so it's a nationally accrediting foundation. So the National Board of Certified Counselors, it is just a different certification and regulation board that you need to make sure that you're keeping up to date with all of the things that are happening in the therapy world. And then the LPC is the Pennsylvania state license. So I'm licensed to practice in the state of Pennsylvania, as well as the state of Maryland, which is, I believe, an LCPC.
Gotcha.
Yeah.
So what about the licensed social worker? I think it's the LCSW title, correct?
Yes. So an LCSW has a social work degree versus a psychology counseling degree. So an LPC has the psychology counseling degree, and an LSW has a social work degree, usually, but they're both governed under the same licensing board in the state of Pennsylvania.
Gotcha. But this is then different from a psychologist. Do you then work with a psychologist?
So a psychologist actually is somebody who has a doctorate in psychology. That doesn't make them a medical doctor. A psychologist cannot prescribe medications. They basically have specific areas typically that they are trained in further, such as assessments, providing specific assessments, IQ tests, things like that, that licensed professional counselors typically cannot do. And psychologists also, they are just on they're a step up from a counselor in the insurance world. So they have a doctorate in psychology. They can do things like they can teach full time. They can, there's just different opportunities for somebody who has a PhD in psychology versus a master's in psychology, which an LPC typically has.
Gotcha. Because we'll refer to psychology, psychiatry once in a while, social worker, professional counselor. So I think everybody has an important role to play. I think sometimes the public gets a little bit confused on who's who and what they do and what their specialties are.
Yeah, I mean, typically when it comes to counseling, when it comes to individual counseling, there's not a giant difference between a psychologist and a licensed counselor. Yes, there's a difference in degree, but usually the ability to provide counseling and effectively support somebody in a therapeutic way, there's not a huge difference. And then a psychiatrist is somebody who prescribes medications. They're usually a medical doctor, and they usually only meet with individuals for, aside from the intake or the get to know you appointment, usually they're only meeting with their clients for about 15 minutes.
And then there's neuropsychiatry, because we'll refer for neuropsychiatry as well.
Yes, neuropsychiatry is a whole different ballgame that is amazing to learn from, but I can't speak to specifically.
Gotcha. So, here you are as a licensed professional counselor, and you're nationally board certified counselor. So you're in sixth grade and you decide, hey, this is what I want to do. When did you decide this is what I want to do? What was that path like?
I think I learned probably pretty early on, probably late middle school, that I wanted to do something in the helping professions. I wasn't really sure what that was. Aside from, I think at some point in time, I wanted to be like a rock star, but like what eighth grade student person doesn't? I think it was around junior year of high school when I really found psychology. Psychology was introduced to me through the book The Chosen by somebody that I could Chuck something with a last name that I cannot pronounce.
Was it The Chosen Potok?
Yes. And
great book.
It was an amazing book. And I read it in 11th grade in English class, and it really spoke to me, and I was like, oh my gosh, psychology, understanding people, understanding why people do the things that they do. That's what I want to do. And I had no idea up until that point that that was a thing you could do. And then from there, I took a psychology class in my senior year of high school with Mr. Vaughn, who was my favorite teacher. And in my senior year of college, there was a very devastating car accident where several of the students in our high school died, and it was tragic. And one of them was one of my best friends, and I was heartbroken. And that class really supported me through that difficult time, and understanding what was going on for me through the brain and psychology and what was happening really helped me kind of work through those feelings of grief. So, and that led me to psychology in college, and here we are.
Excellent. So you also hold another designation, a CCTP, correct? That's a CCTP. So can you talk about that designation?
Yes. So a CCTP is another certification through a licensing board or a certification board called Evergreen Certifications, which is a certified clinical trauma professional. So basically is I had to take a bunch of courses, and every year I have to take continuing education about trauma. And I work closely with individuals who've experienced either individual or a series of or complex traumas. And the reason that I ended up getting that designation and why I hold that one so dearly is because in my line of work, it is very hard to sit across the room or sit across from the camera from somebody and then say, hey, I'm really struggling with X, Y, and Z, and them not have some type of trauma behind it. And trauma is this amazingly just ambiguous thing. Trauma can be something completely different for every individual. So one person's trauma is another person's Tuesday, and one person's Tuesday is another person's trauma. So it really, and when I was seeing that in clients and seeing the need for it, I felt called to really hone in and make that a specialty of mine. So along with that, I also have a certificate from Drexel University about trauma-related disorders. And I'm also EMDR trained, which is one of the gold standards for trauma work and working with individuals with either trauma or complex trauma. And I also am working on IFS training as well, which is internal family systems.
Right. And you threw out EMDR, but we should tell everybody what EMDR is. EMDR.
Yes, sorry. EMDR is eye movement EM. So eye movement desensitization reprocessing. So it is a therapeutic protocol. It's very structured about helping the brain reprocess past traumas and experiences into something that's a little bit more manageable. I'm trained in it. It's something that I have done, and I believe that you'll have Varun from our practice on in a couple of weeks, who really specializes in utilizing EMDR. And I think it's a really amazing protocol, and I think it's a wonderful thing to have in my tool belt.
Yeah, we've referred patients before for EMDR, and we've had some real good clinical outcomes.
Yeah.
So I want to take some time and unpack the trauma issue.
Yeah.
I think it's often overlooked. I think it's often overlooked in a primary care setting. Nothing against those folks are just so busy and they always don't have the time to chat. It's great because I do work with some docs who drew the line in the sand and said, listen, I'm going to treat my patient the way I treat my patient. I'm going to speak to my patient, and they do pick up on that.
Yeah.
So when we talk about trauma, we're not just talking about, I fell off my bicycle, was in a motor vehicle accident. This is deep-seated trauma that I think sometimes happens as a child. When you talk about the ACE studies, if you can talk about that, to how it's expressed now as an adult with respect to symptoms. So we can talk about trauma in of itself.
Yeah. So again, trauma is such a unique experience for every individual. And when I say that, like you said, it could be deep-seated, it could be rooted from a childhood experience, whether it be a physical abuse trauma, an emotional abuse trauma, a neglect. It could be an attachment wound where a relationship between a parental figure or a caregiver has been severed or injured, and it affects how the individual goes on to live their life and interact and relate with the world and other people. So it can run the gambit, but it could also be a car accident. It could also be a death in the family or a death of a loved one. Trauma can be experienced in any which way. The thing about trauma that a lot of people don't seem to recognize is that it's not like this thing happens and then everybody heals and they just get over it and time heals all wounds. A lot of times trauma is integrated into how we see ourselves, how we see the world, and how our body functions. So that's where you're seeing a lot of trauma, I'm sure, because when we experience a trauma, our body holds on to it. Our body experiences it just as our psyche does, just as our emotions do. And I think that it's a lot of times overlooked in a primary care setting because it's seen as anxiety. And anxiety is so commonplace nowadays, and anxiety is so overlooked that, oh, well, they're just anxious or they'll get over it. And there's also a huge divide culturally and in our society, especially in America, where childhood trauma, there's this line that in the sand that people tend to draw that, one thing is considered childhood trauma and one thing's considered normal. So if it was culturally appropriate for spanking to happen in one family, but it wasn't in another family and it's experienced as trauma, it depends on how the person's interpreting it and how it's being held inside of the body and how they use those experiences to relate and understand the world.
Gotcha. So in our practice, we'll see this met out in, our irritable bowel patients.
Yeah.
We'll see somebody with long-term chronic pain, and that itself is trauma, right? So we forget that a chronic diagnosis in of itself is trauma.
Yeah.
And we'll see that in our autoimmune patients as well. We find that, we can get the right supplements going and we can get the right nutrition going and dial in exercise and sleep. And we're getting some good improvement subjectively and objectively, but then it's like there's this one piece that's missing, and you kind of dig a little bit deeper and it's like, okay, so now it's time to sit with somebody.
Yeah. And a lot of times that's when people start to realize, oh, I don't have an illness or I don't have a disorder. Like I just am experiencing, 30 some years of living with this trauma and my body is sick of it. Right. So there's a lot of research out there that can find the connection between childhood traumas and physical ailments later in life, specifically autoimmune disorders, and chronic pain and chronic issues in general that can be linked back to a correlation between high ACE scores. And that's the ACE study, which is the Adverse Childhood Experiences. And it's basically just a survey that is done. And it's done in a lot of areas. I know a lot of primary care doctors do it. A lot of medical professionals do it. We do it in our practice. They do it in the university settings. In a lot of caretaking settings, the ACE study is given to, or the ACE survey is given to individuals to kind of understand what they've been through. And it really evaluates how many experiences prior to the age of 18 that were considered a potential trauma and puts them more at risk for potential PTSD type symptoms.
Gotcha. And I'm always wondered this, and maybe you can talk to us. Stepping outside of the United States, how is trauma received and treated? Like we were talking about, we step into England, if we look at Spain, if we look at Germany, if we look at Asian countries, how is this viewed? Is it seem more like it's us, or obviously it's worldwide, but how is it perceived? How is it viewed? How is it treated?
Well, I think it really depends. I think I really can't speak to that specifically. I don't really have a clear answer on that, but culturally, just knowing some cultural norms and expectations within certain cultures, I imagine our definition of a childhood trauma is probably also different than another country's. understanding of what a childhood trauma is. So I can't speak to that directly. I could make a lot of assumptions and I could surmise a lot of things, but I can't speak directly to that.
Yeah, I think one of the things we often see here is the overbearing parent who's like, you got to get A's, you got to get, if 4.0 isn't good enough anymore, and you need to start a nonprofit company on the side, and
Yeah.
I think that in itself is traumatic for
Yeah.
someone being 14, 15, 16, 17, 18, and just
hmm
work, and
hmm
so do you see a lot of, I can't say education related trauma, I'm sure there is, but I mean there's just this setting of this young person who is struggling with our new social norms anyway, and the internet and all that, and on top of that just having to work so hard to possibly get in somewhere with no guarantee.
Yeah, a lot of times what we see in those types of family dynamics are where the child has these high, the parent has the high expectations for the child, right? And if the child feels as though that is where their value or worth comes from, right? So then this internal working and conceptualization of how we interact with the world and how we interact with each other and our relationships and how we feel love and affection is also tied to productivity. It's also tied to high achievement. It's also tied to success. So a lot of times we're seeing, high school students experiencing adult-like mental health issues like severe depression, because their own internal understanding of themselves is so tied to somebody's external expectations. And and we could conceptualize that, like you said, as a trauma. And so much of trauma work is internal workings. And as Americans, we don't like that. We like everything to be external. We don't want to look inside. We don't want to deal with our own stuff. We don't want to look at our own, faults and struggles. We want to look for an external fix. We want to look for, somebody else is the problem, or, and try to kind of rework some of those, internal wounds that have occurred because of external factors.
Right. So, it's easier to run a mile than to have introspection, because introspection is damn hard.
Yes, it is.
So what do you do with this young person that sits in front of you? You've spoken to them, you now have an idea like, hey, they're suffering internally, right? This is internal strife, this internal family strife.
Mm-hmm.
But now you got to say something to mom and dad. I mean, that's got to be sometimes like, don't say something to mom and dad. I don't want you upsetting mom and dad. I mean, that's got to be very difficult at times.
It is really difficult. And I really do think it has, I don't work with a lot of children. I work with adults typically. I think the youngest individual that I typically work with is, just turning 18. So they're technically adults, right? Mm-hmm. So I'm sure that somebody who works with, the pediatric adolescent kind of population would feel differently about this. But my ultimate goal is to help somebody feel comfortable inside of their body, inside of their mind. So helping them understand that call to want attention, affection, that call to want praise, or, looking for external worth and value, to find a way to turn that internally. And one of my favorite ways to kind of express that, and, as a therapist, I am who I am, whether I'm, in the therapist chair or I'm not. I'm going to speak to my clients like I speak to anybody in my life. And I have that in my profile. If cursing and sarcasm isn't your thing, then I might not be the therapist for you. So, but I'll say to my clients, like, that feeling of whenever you do something and you look up and you want somebody to say, good job, or you are doing something and you want to show it to somebody or share it on social media. That's the time you should be turning in and looking inside and saying, okay, what do I need to be feeling right now? And how can I give it to myself?
Gotcha.
So, and that's different for every individual.
Right.
Right. It might be a reward. It might be a praise. It might be, taking time to meditate. It really depends on what that individual needs in that moment.
So kind of related to that thread, we talk about young people, and there's always this thing with, boys don't pay attention in school, or this boy, he has ADHD, or it used to be ADD, I guess, and now it's just ADHD. We'll talk about that. There, for me, the always understanding was like, hey, boys need to move, right? So they put them on the stability ball, and they have better focus because they get to move around a lot, right? I mean, we just know that. I know for a while, I mean, teachers did not let kids daydream. Like, stop. What are you daydreaming again? I mean, for me, I was assuming that I had the book inside the book all the time, right? If you don't bother me, I won't bother you. Let me read, and we'll all be happy.
Yeah.
So, but that diagnosis now of the ADHD has now come later for a lot of folks. Like, they may be struggling with this when they were a student, a young person, and they're saying, oh, you have a learning disability, you have this problem, you have that problem. Or maybe not say anything at all because nobody says anything. And then later on, oh my gosh, I've been diagnosed with ADHD. So can we talk about that? Can we talk about what it is and how does it get diagnosed, and what do you see in your practice?
Okay. So let's just look at ADHD let's look at it first as like a social construct, right? So let's think about traditional. So, the traditional idea of a little girl and a little boy, traditionally, like we're totally talking traditional, stereotypes of little girls and little boys. Little boys, for like you said, like to move, right? And if you think back to your experiences in like elementary school, most of the time, the bad kids were the boys because they didn't sit down. They wanted to run around. They interrupted. They were raising their hands and jumping instead of just waiting their turn. They seemed like they were balls of energy, right? That's traditionally and stereotypically how boys function. But it is not what is expected of students, right? Whereas traditionally and stereotypically, little girls, typically sit in their seat, have a little less energy, usually are typically a little bit more meek and mild and in manners, right? So it's really easy to recognize when a little boy can't keep it together, when they can't focus, when they aren't learning, and they just can't sit still. So usually it's an external force, like a teacher or a parent saying like, he's too much, like I can't. And it's easy to see the external symptoms of ADHD, right? Now, what we're finding now in women, in little girls tend to adapt to the learning environment much easier and find ways to cope or mask, so to say, in the learning environment. So a lot of little girls had the same ADHD diagnosis, but were exhibiting different symptoms. So instead of jumping up and wanting to raise their hand, they were the ones daydreaming or drawing their names in the books. Or they were the ones, that didn't listen at all during school, but then had to go home and teach themselves everything again. Right? So they were the little girls, that either were doing really, really well in school because they could adapt to school and they could adapt to the social construct of school, but they were struggling internally. A lot of the times the boys' experience is an external factor where the girls a lot of the times were turning in. So now, because school is much more traditionally and stereotypically formulated or a better setting for little girls, it's easier to mask it. It's easier to hide it. It's easier for it to slide under the rug, especially if the girl is intelligent. If the girl doesn't struggle in school, if the boy doesn't struggle in school, and they're just smart, intelligent kids, no one really thinks to question an ADHD diagnosis. If you're intelligent and you're getting good grades, then you can't have ADHD, right? You're doing fine, right? But then what we find specifically in women is there's a higher frequency of diagnosis later in life because we're not in the school setting anymore, right? Especially when we get into our late 20s or early 30s, we have different responsibilities. We have a career, we might have kids, we might have husbands, we might have households, and now we got to figure it all out. And it's not just sitting in a seat and attending and being a good little girl and listening. Now it's holding relationships, remembering tasks, doing the mental load of being in a relationship and having kids, holding a career and being successful in a career because, you know, that's what you have to do, right? So a lot of women start to recognize these symptoms of ADHD later in life and many times are misdiagnosed. So they go to their primary care doctor and they say, I can't focus, I have brain fog, you know, I'm getting in fights with my husband or boyfriend or girlfriend, like partners. Like I lose stuff all the time. I can't keep it together. My house is disorganized. And they're like, oh, well, you're probably depressed because you can't do the things. Or you're probably anxious. That's why you're getting in fights with your significant other. Or, you know, oh, maybe a borderline, like maybe a bipolar disorder. Like that sounds like you can't sit still. That sounds like mania. And a lot of the times they're misdiagnosed and the actual diagnosis of ADHD is completely missed because they're not looking at women specifically. And I'm sure that this generalizes to men too, but I'm going to specifically speak to women because that's what I'm working with in my practice. Women are being misdiagnosed. They're being, they're being dismissed when in reality they're having the inattentive version of ADHD. And in, many of the, different subsets of the therapeutic community, there's a lot of push to change the name of ADHD, attention hyperactive, oh my gosh, AD. Speaking of ADHD, so attention deficit hyperactivity disorder, right? So, there's a lot of, thoughts out there that maybe that's not right. Maybe it has nothing to do with hyperactivity. And the reality is that it's an executive dysfunction disorder. There's this difficulty for people to really do the tasks, to, especially women are finding the difficulty of like, I can't get off the couch to do the laundry. I want to do the laundry. It'll take me 4 seconds to throw that into the laundry, but I just can't do it. Right. Mm-hmm. So it's seen as on the external side as laziness. It's seen as, disorganization. It's seen as, she's overwhelmed, she's taken on too much, so on and so forth. But in the reality is the person is having an executive dysfunction where they just can't get themselves to do it. They can't do these things that their brains are trying so hard to do and that it comes naturally and easily to other people. And a lot of times for women, it's coming later in life because of different responsibilities. And a lot of times also hormonal disruptions after pregnancy, after menopause.
Right. So that was one of the questions. So, we asked in the beginning, like, how does menopause affect ADHD? Does menopause bring about ADHD? If it is a executive dysfunction, mm-hmm. then how do we approach that from the perspective of medicine? Because a lot of times we'll try different medicines, mm-hmm. And then therapy. Because in our world, sometimes we've seen some PubMed work on saffron. Mm. I know Dr. Dan Amen, MD, Brain, he does saffron for ADHD. Huh. I think it maybe helped a little bit. So that I've seen that happen. A lot of times, patients just go on the medications that are given to them, and because I can't blame them because they just want some kind of relief, right? So yes. Not that it's pain relief, but it's relief to have some focus.
Yeah, no, and there's as far as the medications, is there a place for it? Yes. Absolutely. There's a place for some individuals, absolutely need it. Some people need medications so they can go to therapy and get what they need out of therapy so that they don't need the medications. So that's the camp that I really like. I like the camp of, okay, well, I can't do this on my own. And, therapy might be too overwhelming or, is difficult for me in this moment. I might need something to get me to the point where I can do therapy to get the most out of it. But at the same time, stimulants are not a great option. for a lot of people. Individuals who have histories of drug addiction or family histories of drug addictions, stimulants are, can be used as a street drug. So, and they can be addictive. So it is really a deeply personal choice to choose to do a medication, but there's plenty of things that you can do in therapy and lifestyle and addressing things of your own health that are also getting in the way, because you're looking at executive dysfunction and you're looking at issues with dopamine, that reward center, right? So there's some arguments out there against it, but there's still some arguments for the fact that individuals with ADHD or ADHD type disorders lack dopamine or don't access dopamine in their brains as easily or as well as somebody who is, neurotypical. Okay. So it's really a personal decision on the medication part, but understanding what you're experiencing and what your challenges are, and finding ways to cope and finding ways to address what you're experiencing and make your life fit your needs. So one of the things I say to a lot of my clients is, we're neurodiverse individuals living in a neurotypical world, right? So everything around us is for people who don't have executive dysfunctions, right? Like, for example, my laundry is in my basement. For the average person, that's probably not a problem. But for somebody who struggles with executive dysfunction, that's 3 flights to get into the basement to put my laundry in there, right? And then it's also 3 flights to carry it back upstairs and then fold it and then put it away. There's a lot of barriers for somebody who already struggles for that get up and go, for somebody that already struggles to maintain structure and routine. So would it be, in an ideal world, my laundry room would be upstairs next to my bedroom, or even in my closet. Hey, that would be even better. And if you have the ability to make lifestyle changes like that to make your life easier, it makes the ADHD more manageable.
Gotcha. So staying on the thread of the executive dysfunction, and we know that the medication works as a chemical and a supplement can work as a chemical. So does therapy then teach them a new habit to then actually tap into executive dysfunction to actually make it better for them?
Yeah, it can. A lot of times, so what they say about stimulants and medications for ADHD is it closes the gap that individuals with ADHD have. So it closes that gap of there's this thing I need to do. There's a gap doing the thing. So stimulants, in theory, close and shorten that gap so it's easier for the person to do the thing, right? So the goal in therapy is to do the same thing without the chemical. So a really simple example of that is I had a common issue with women that I've talked to with ADHD is I can't get my clothes in the hamper. They're on my floor. I have doom piles all over my room. I have the pile of clothes that, aren't completely dirty, that I wore once that I could probably wear again. And then I have the other pile of dirty clothes, but for some reason they come off my body and they end up on the floor and I don't know what to do. And when you really talk to them about it, when you get into it, they're like, well, they end up, sometimes I can get them on top of the basket. So if you look at it, the barrier is the lid to the laundry basket. And that one tiny little change or adjustment in their life, getting rid of the lid of the laundry basket, has been life-changing for so many individuals that I've talked to. I took the lid off that laundry basket and it's my whole life changed. I haven't had a piece of clothes on my floor in months. I was like, okay. So it's really figuring out, okay, what is the barrier? What is the thing that makes it too difficult for you to do that thing? And that's just a very basic example of that. But therapy is helping them identify what is the barrier, what is the thought process that's holding me back, what is the actual thing that's holding me back, how can I change the thinking, and how can I change my environment to better fit my needs.
Gotcha. So how does your thinking then change in the therapy seat with someone who has difficulty with like focus? So we can say this individual just won't put their clothes away. We're talking about someone who's going to sit down and read something or write something, and they're like, while they're oh look a chicken, and like right, and it's like they can't hold the focus. So in the writer circle, sometimes they talk about using like the nicotine patches when they're going to write because that's a stimulant. So you're not smoking the cigarette, you're getting this rush and allows them to focus.
Well,
that's a great idea personally, but I hear about this all the time, right?
Yeah.
So what do we do with that person that has that focus issue? Like, they're not lazy, they or consider lazy, they train, they do all these things, they'll cook dinner, but boy, they just can't seem to hone in.
Yeah, the thought process is very similar. And also, you're speaking right to me. I am easily distracted by chickens. I love chickens. So if you throw a chicken anywhere near me, I'm going to look at the chicken. So sidebar, just wanted you to know that about me.
Gotcha.
But when it comes to focus, it really is the same thing. So I've worked in the university setting, and I have worked directly with students who are going through, the disability process at school because they have ADHD, and really helping them figure out, okay, I can't listen. I can't focus. Okay. So you help them figure out how they are successful. So if it's reading a book, okay, why can't you read more than a page? Well, I find myself reading the same line over and over again because I keep thinking about something else. Okay. So if it's because your brain's getting distracted by intrusive thoughts, unwanted thoughts that you don't want to be having right now. Okay. Well, that thought has value. And a lot of times what happens for the internal processing for somebody with ADHD, if they have an intrusive thought that's getting in the way of their attention, they're reading a book, they think, I got to pay my car payment. And then they read the sentence, got to pay that car payment. And that internal, like, I can't stop thinking about this because I will then forget about it, is usually many times the barrier, right? So very simple workaround. If you're reading a book, keep a Post-it note on the other page, write down the intrusive thought.
I like that.
It now has a place. You're not going to forget about it. It's on your Post-it, right? So it's now no longer an intrusive thought. That's not to say that another intrusive thought's not going to come, but you now have a skill to deal with that you don't need to take a medication for, right? And these are all super simple things and very specific to specific problems. And I recognize that. And that's why therapy is so unbelievably important for individuals with ADHD, because you can live a life with ADHD and not feel like you're drowning in your own brain and inside of your own body. And the attention. Another thing is grounding. Grounding is like, I feel like it's the Band-Aid for all therapists is learning mindfulness and grounding, right? So, but it's so important to be able to be mindful and grounded inside of your own body. And individuals with ADHD really struggle with that because they got so much stuff going on up here that it's really easy to be disconnected to what's going inside of the body and what the brain's supposed to be attending to, right? So if you are somebody who struggles with staying grounded in a classroom, so to say, I love the idea of doodling. I also tell people to bring, multicolor pens to class. So bring multicolor pens to class and go at it while you're listening to your teacher. And there's something about, and one day I'm going to find out the science about this, but I teach people this skill and I don't actually know the actual science behind it, but for whatever reason, drawing like a tornado, like a cyclone type thing, tends to keep people grounded enough with the tension and the difference in tension of the pencil or pen on the paper that it keeps them grounded and focused enough that they can usually attend to the things around them while still being grounded in that moment. I don't know what it is about it, and I should, but I just know it works, so I tell people about it.
That's very interesting. It's a great tip, and also having the Post-it notes a great tip as well. A lot of my patients will complain that it's nighttime, they go to sleep, they close their eyes, and the term is ruminating. It just just keeps going. And, we have them do the body checks. We have them create a nighttime routine, just like there's a nighttime routine for, little kids. I think most adults don't have nighttime routines. They should have nighttime routines.
They should.
And fantasy is 90 minutes without any screen time of anything. I'll take 60. 30, I'll take whatever I can get. And keeping that far away from, it doesn't need to be in your room, because, again, especially if you have notifications turned on, because that very Pavlovian, like, ding, and then you're already thinking. So
you hear the ding, you start drooling. It's a whole thing.
It's horrible, especially if you're drooling on the person next to you, which isn't always good.
It makes sleeping it makes it unhappy for everybody.
It does. Unless they don't know, then it's just fun for the single ones. But we digress. One of the things that I shared in the beginning was somewhat of a case study of a 54-year-old female going through menopause. Can menopause exacerbate ADHD? And, again, you talked about things that we can do, which I thought was wonderful, not just medication, but above medication. We have the same thing in ours as well. Somebody has an acute neuromusculoskeletal situation, medication will calm it to get to the office so we can treat them for them to come off the medication. We'll see that with irritable bowel. They need to be on some medicine first. We change lifestyle around diet, and then we come off the medicine. So I think it's a wonderful pairing. So with this individual, they also had a gene site test, which then talked about, like, they just cannot process it. They can't metabolize the stimulant too fast. So they take the medication, nothing happens. So if you can share your knowledge about what is gene site testing, because I found it really interesting, who uses it, how somebody can get it, how you use it in your practice, and how menopause affects ADHD.
Okay. So gene site is something that needs to be completed by a medical professional in some way, shape, or form. So usually a psychiatrist, a primary care doctor, or a psychiatric nurse practitioner. They'll usually use the gene site testing as a way to identify, in a class of medications, which your body would react to the best. So let's say there's, in stimulants for ADHD, there's a handful, right? It'll use, I believe it's a saliva test. And you basically send it off to a lab, and that lab will determine, okay, let's say Adderall, Vyvanse, Concerta, and Strattera. Let's say we got those, right? And it'll say, well, you're going to metabolize these two faster, meaning your body isn't going to maintain the benefits of them for as long as it would for, let's say, Vyvanse. But Vyvanse, you're still metabolizing really quickly. It's not going to be significantly better. You get to decide, okay, well, do I try the one that's, say just a little bit better, or do I don't try these at all because the gene site is telling me already that I'm going to metabolize them and not really get the benefits of them that I should be. So we don't use it in our practice because we don't have a medical professional on staff with us. I know plenty of other practices locally with medical professionals on staff that can use it. There are a couple of prescribers that I like to work with who do use gene site. So if I was working with an individual and I said, yep, it's time for us to consider the medication interventions, it's time for that, I would recommend to them to talk to their provider about gene site, just to narrow down the options, right? Because when it comes to mental health stuff, medications are really, really individualized and really hard to get the first one on the first try.
Have you ever seen any discordance with the test saying one thing and medication doing something else, or is it really pretty close?
I mean, I think sometimes medications work the best they can, regardless of how they're metabolized. When I was working in community mental health, I did have one experience where somebody was on a mood stabilizer that the gene site said that probably wouldn't be the best for them, but it was working fine enough because that was what their insurance covered and that's what they were used to taking. And that's what didn't have, any side effects in correlation with other medications. It worked fine. Could they have used another one that was better? Maybe, but that may have interfered with some of the other medications. So it really is super individualized. Gotcha. Yeah. And then to the question about the menopause, Yes. Again, because again, our bodies change hormonally, and specifically for women, when there's a drastic change in hormones, it can affect mental health. And there's a lot of research about birth control and how birth control affects mental health, and
Mhm.
a lot of them also say that there's not any direct correlation or causation. Anecdotally, most of the women that I've personally worked with who are on birth control, it affects their mental health in some way. um, Obviously, for many people it's needed, whether it be for lifestyle or for physical health needs, but the bottom line is that it affects our hormones, and our hormones affect how we experience emotions, and experience different external factors. So if we look at menopause, common feelings experienced for women during menopause are irritability and feelings of overwhelmed and overstimulation, right? So if you're somebody who has already experienced those things but have dealt with them most of your life, like, I'm already overwhelmed, I'm already overstimulated, but like, I'm doing okay. And then menopause comes in and says, just kidding, no, you're not. No, you can't handle this. Then of course, that's when ADHD might become unmanageable. It might be in fifth grade when you have to learn, I don't know, what do you learn? What type of math are you learning in fifth grade? Let's say geometry. I don't know. But I remember in seventh grade, I think I was learning pre-calculus. And I remember that being like, nope, can't do this.
Right.
So there's certain things in our lives that we get to a point where, if you are somebody with ADHD, that might be the thing that is too much that you can't work your way through, that you can't mask your way through, that you can't hyperfixate your way through, that you can't like just work through. And for a lot of women, that's, birth control. For a lot of women, that's their first pregnancy. For a lot of women, that's menopause.
Right. So I mean, like one of the tests when you, Runa and I were talking, I shared the Dutch test, the dried
Yes.
urine fetal competence hormone panel. So with you sharing that, my brain then goes to, okay, well, if you run that test and you see kind of like what's going on as you go into this,
Mm-hmm.
you kind of have a good idea of what you can try, at least from the
Yep.
natural side of things first, to
Yep.
support them
Mm-hmm.
in combination with your treatment.
Yeah.
So,
So so in theory, if the Dutch test comes back and you identify there's like this huge spike in, let's say, cortisol, maybe that's the hormonal change that made the management of the ADHD too much for that individual, right? So let's say that's the issue. You manage the cortisol, things become more manageable. Do you still have ADHD? Probably, but you're probably just managing it and dealing with it fine, that it's not a problem for you.
right, I think that's where that can play like a significant role. So
Mhm.
with this specific case, with the
Mhm.
person that just really just metabolizes the stimulant too fast,
Mhm.
they're running out of options.
Yep.
But the one option they should try really is sitting with a professional because that's important. So
Yep.
I'm sure during that setting there, you have to tease out other things that can
Mhm.
also be contributing. I mean, there's
Yes.
stuff that happens in all of our past. I mean,
Mhm.
and current obviously as well. So I'm sure
Yeah.
that must play a role.
Yeah, absolutely. When it comes to like diagnosing ADHD, when it comes to that specific diagnosis, the waters get a little muddy, if I'm being fully honest, because here's the thing. If you are a parent of a child that you think has ADHD and you want to go ahead and get an IEP and accommodations for them in the school, you should be going for some formalized testing. You should probably be taking them to a psychiatrist who is very well versed in recognizing the symptoms and severity of this. If you are an adult person and you are struggling just to get your life together a little bit and it's causing issues with your relationships, and you want somebody to help you cope with it, and maybe talk to your primary care doctor about maybe possibly considering ADHD medications, a licensed professional counselor in the state of Pennsylvania is technically able to provide provide diagnosis for anything from the DSM-5. So, and ADHD is considered is in the DSM-5 or 5TR or whatever the version is right now. So you can go if you're looking for specific ADA, Americans with Disability Act accommodations, or if you're looking for, an IEP for your kid, you might want to go to a psychiatrist and get the formalized diagnosis and then go talk to a therapist who knows what they're talking about with ADHD. If you're somebody who is, pretty sure you have it and you don't need it like formally diagnosed for, work or school or whatever, talk to a therapist who is understanding of, neurodiversity and ADHD and can help you tease out, is this ADHD? Is this something else? Is this underlying trauma? Or am I just an overwhelmed person that needs to figure out how to live life? Not everything has to be a diagnosis. Sometimes it is just life is hard and parenting is hard and living life in America right now is hard. So sometimes you just need somebody to talk to you and help you understand that.
Where's living life not hard? Let's go there.
I wish I knew. Sometimes in my head, sometimes I can go to my happy place and things are good.
Well, listen, it's always 82 and sunny up here, like most of the time. Anyway, so.
82 is a little warm for me. 78.
It's warm. It's nice. One of the questions I want to ask, because we touched on trauma.
Mm-hmm.
Do you find that there is a correlation between trauma and ADHD?
I think you can find a correlation between trauma and pretty much any diagnosis, honestly. And there is a camp of individuals and therapists out there that do believe, I don't know if I fall in this camp completely, but there is a camp out there that believes that ADHD can be a trauma response. So, and I guess if you look at attachment, if you look at childhood attachment, you look at attachment disorders, and you grow up in a disorganized or avoidant household where, your parents aren't secure and your parents aren't teaching you the skills that you need to have as a young kid to live in the world and function and understand how to live and do life, I can see that could definitely be related to ADHD. Do I think it's the issue for everyone? No, absolutely not. I don't think that that's the case. I think that for many individuals, it can be a contributing factor. Yes.
Gotcha. And staying on the line of trauma, we're hearing a lot of work about, psilocybin. Any thoughts on that? And I'm not advocating anybody do this on their own, be under professional guidance, all that kind of stuff.
I have zero information. I have zero thoughts. It is, one of my roles in one of my positions is I am an alcohol and other drug coordinator. So I provide a lot of education about making safe decisions around drugs and alcohol. So that is a topic that I would have to do a deep dive on that I have not yet. And I've been avoiding, but I also know that there is a lot of talk about it, right?
Yeah.
A lot of discussion out there, a lot of talks out there. I'm probably going to start with, I'm pretty sure I saw Andrew Huberman did a podcast about it recently. Yeah. So I'm going to have to carve out like 3 hours or however long his podcast was to start there.
At least closer to 4. He did one with Tim Ferriss. Tim Ferriss talked about it as well. Saw Huberman at the Beacon Theater. He had a fantastic presentation, absolutely fantastic. He
is fascinating to listen to. If I have actually recommended many of my clients to listen to the podcast that he does about your relationship with alcohol, which is a life-changing episode. Yes. If you really truly listen to it and you really want to do that introspective work, that is a really powerful episode. And then my individuals that I work with who have bipolar disorder, who need to understand it on a brain level, on a neuroscience level, I also recommend it to them or the people that they love and care about, because that was also a really powerful episode as well. But back to the topic at hand, the only thing I can really say is, in the world of alcohol and other drugs, we saw marijuana as a drug. Then we saw it as a potential medication. Then we saw it as a medication. And now that it's this weird little medication drug baby, and we're not really sure right now what that is. And I imagine that psilocybin's going to be coming up shortly thereafter in the same trend. So I'm not informed right now, and I intend to be. I just am not right in this moment.
Gotcha.
Yeah.
So my next question to you is, how does somebody find a good therapist? What should they be looking for when finding a good therapist? So everyone, as you can imagine, like, does my insurance cover? That's the first question, right?
Yeah.
Nobody asks about quality. They just want to know, does my insurance cover, right?
Yeah.
So
yeah. So when it comes to finding a therapist, we're taught time and time again, and I think it's very, very true, that one of the most powerful and important things in a therapeutic relationship is that you have a good trust and connection with your therapist. So if you meet with a therapist and they're just not vibing with you and they're just not your jam, it's not therapy, it's that person. And there's nothing wrong with that person. They're probably vibing with plenty of other clients and things like that. But the first thing I want to say when finding a therapist is the first one could totally suck. Your first therapist could not be the right one. Not that they're a bad therapist, they're just not the right one for you. And a good therapist, even if they're not the right therapist, will help you find somebody who is better for you. There are a ton of ways to find therapists out there. There's a ton of directories out there. The most popular one out there is Psychology Today. The one I like the most is Therapy Den. I think Therapy Den is a really good platform to go on and look for, therapists. And it's kind of like a dating profile. The therapist is on there with pictures and they're talking about like what their specialties are, what they're going to do to help you, and blah, 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 blah. And all those directories have that. The downside with using an insurance is they just throw you a list of names. So if you call the back of your card of your insurance and you say, I have, Independence Blue Cross, you call Independence Blue Cross and say, hey, I want to see a therapist. They will send you a list of a ton of providers. Most of them at this day and age are probably not accepting new patients. And, you don't know anything about them. They're just a name. So if you are using insurance and you choose to do that, what I always recommend is find the name, take the name, look them up on the internet, find their profile, see if they're the right one for you, see if they offer a free 15-minute consultation. Most clinicians offer consultations to some degree, whether it be an email exchange, a phone call, a 15-minute video call, whatever it might be. A lot of places do that. A lot of places that accept insurance might not, but the private practitioners that don't accept insurance or provide out-of-network benefits usually offer that service. So you can look through your insurance and then try to look up the individual therapists online to see if they're a good fit. Or you can just go on into a directory and there's ways to set like your budget. I want a therapist who is virtual, but I only want to spend, $100 or $150, and this is what my budget is. You can do it that way too. So what I always recommend is, one, look them up, see if you vibe with them on their profile, and secondly, schedule a consult with them. And that consult really is to see if you guys click, to see if the relationship is there, that you feel comfortable, you feel safe. And if not, thank them for the free 15-minute consultation and move on and try somebody else. And I think that that's probably the best way to find a therapist.
Excellent. And you touched base on as briefly, and I think it's important, is the internal family. Can you tell me again, the IFD, internal family
systems? It's a therapeutic approach.
That's right. So can you talk about that?
Yes. So it is an up and coming, very popular, treatment modality traditionally it can be used for lots of things, but traditionally used for trauma. And it's really the understanding that, and I'm very early in my training in it, and I don't want to misspeak or say the wrong things, but how I'm conceptualizing it and how I understand it is that when we experience a trauma, in order to survive that trauma, in order to live through that trauma, our self breaks into parts. It breaks into pieces. And there's different parts of us that keep us safe and protected in the best way that those parts can from the trauma or the perpetrator or the experience. So, there's protector parts, the ones that are, maybe doing things that are helpful or not so helpful, that are helping you get through the trauma. So, for example, a protector part could be the part of you that drinks too much at night. It's not a healthy thing that you're doing, but you're drinking too much as a way to protect yourself from the pain of the trauma that you're experiencing internally. And internal family systems is really helping, bring out the self energy, the person who has experienced the trauma, but that person currently, in today's day and age, really understand their different parts, what functions those parts have served and done for them, and thank them for their service, and find a way to live in their self energy and in their self most of the time, if not all of the time, through healing the different parts.
That's beautiful. I like that a lot.
It's really cool. I just finished a 2-day workshop on it yesterday, and it's really speaking to me. So I'm excited to do a little bit more about education and hopefully some training on that in the future.
That's wonderful. So my next question is, like, how can somebody work with you, and how'd you guys come up with the name Hope Stream Counseling? I like that name. How'd you guys come up with that?
Thank you. So our website is hopestreamcounseling.com, and our email is contact@hopestreamcounseling.com. We have currently 3 clinicians. We are a virtual only private practice, private pay in the state of Pennsylvania. I'm the only clinician licensed in the state of Maryland. We have 3 clinicians, myself, Varun, and Pamela. We all have different specialties and different areas of passions when it comes to therapy. So you can check out our profiles online on our website. Our profiles are all on there. And then you asked the second question, and I totally forgot it.
How you came up with Hope Stream Counseling as a name?
So, I should probably go back and really write down the story of how we found it. But my husband had certain things that he wanted in it, and I had certain things that I wanted in it. And we came up with a bunch of different names, and we sat down and looked up the significance of those things in the world, and we kind of patchworked it together. So we find, hope, pursuing hope together. That's where we function as clinicians, is that if you don't have hope, you can't do healing. So if you've run out of hope, we're here to help you find the hope so that you can heal. And then stream, water is healing, but it's also extremely powerful and dangerous. So we wanted to make sure that there was a component of water in there. And there is also some biblical references in there, because that was important to my husband for his faith and his motivating factors in life as well.
Beautiful. Absolutely beautiful. And before I let you go, my next question is, what book are you reading now?
Oh, I'm not reading it yet. I just ordered it. I ordered Jill Winger's Old Fashioned on Purpose book. I love her. It's not a therapy book. I also am working my way through Body Keeps the Score. But it's a great book. It's just a big book. Yes. It is a big book that you need a lot of attention for. So I'm working my way through that slowly. And Old Fashioned on Purpose, I have a passion for homesteading. My husband and I want to own a farm with some more chickens and some other animals to live a slower, more peaceful, more mindful life. And Jill Winger is kind of the queen of that in the homesteading world, is really bringing it back to the basics. So I'm excited to read from her and learn from her.
It's absolutely beautiful. Get some billy goats. I love billy goats. Billy goats are wonderful.
Fingers crossed. I'm also kind of obsessed with baby doll sheep right now. So it's my current obsession.
Very cool. Well, thank you so much. I really appreciate you taking the time tonight. If anybody has any questions, please feel reach out to us, and we'll get you those answers. Everybody have a good night. We'll talk to you soon.
Thank you for having me. Thank you, everybody. Bye-bye.